right, Tyler, we're back.
Yes, sir.
We're doing it again. Welcome back to the next installment of the Many Minds podcast, where we encourage collaborative community healthcare using many minds for better outcomes. I'm Alex Davis, physician assistant. I've got with me, as always, Tyler Murray, nurse practitioner, and the two of us work together at Summit Brain, Spine, and Orthopedics in Lehi, Utah. If you've listened to us before, you know the spiel. If you're new, let me fill you in. The reason we're doing this podcast is to promote interaction between the different specialties. As advanced practitioners, we always want to know, what is everybody else doing? How can we help you? What makes your specialty so special? And kind of help us understand what's a day in the life like for you.
And with that, we always want to mention our general disclaimer. This podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not intended to act as a medical substitute for medical advice, diagnosis, or treatment. We're just here to talk and have a good time. And as always, I start this off the same way. We're going to jump into this week's podcast. Today, we're going to be talking about the world of pain medicine a little bit. We might go elsewhere too, because we have Jeff Atkinson here. He's a nurse practitioner and been in the game for a little bit, so seen other specialties, but currently practicing in pain medicine. Is that correct?
Yeah, 70% of my work is pain medicine. I still do family medicine, urgent care, infusion services for Premier Family Medical.
And was it like something new as far as the pain medicine being incorporated into that, or is that something that's been happening in the background for a long time? Kind of, how did that process really start? How did you get into that?
Yeah, so when I was first going through nurse practicing school and was doing my clinical preceptorship, one of my rotations was with interventional pain and spine. And I carried that on and actually worked for that group for a while. Had a transition in my career, went up to the University of Utah, worked out of the College of Nursing for some time. Came back and I've been full-time with Premier Family Medical, who's been expanding their clinical specialty beyond family medicine to help support patients within the group. And as a part of that, they hired Dr. Holden Brown, who's our interventional pain spine guy. And in that,
great guy, by the way.
Oh yeah, he's a great guy. He's very good clinician, very good surgeon. So
easy to talk to too. I've always had a
so
good time interacting with him. Yeah, he's great.
Yeah. So when they brought him in, they thought we'd be a good fit. My background and some of the other stuff I do with Premier, they thought it'd be a good collaboration. So they moved me over, and I've been with him out of our Linden clinical office for about 18 months now.
Nice.
So back in and more focused on pain management.
So kind of talk to us a little bit. I'm kind of taking over.
Have at it. I love this.
I got the mic now. All right. Just tell us a little bit about your day-to-day and what that looks like. I mean, I think we generally have an understanding of when we refer a patient to pain management, what that entails, but maybe through your lens, kind of talk us through kind of what it looks like on a day-to-day, week-to-week basis.
Yeah, so I mean, there's a couple of different things we could talk about with that. Pain in and of itself, and what we can expect or see, and how do we deal with people's chronic pain and address that, versus more of what a day-to-day role for a nurse practitioner PA might be. It's probably easier to start there, and maybe what more patients are listeners are going to be looking for. But as far as for me, it's management of chronic pain daily. We evaluate chronic pain as pain being there for more than 6 months or more. And so ours, where we're a more internal based referral, we have 40 APCs, or advanced practice clinicians. We have about 38 physicians, DOs, and between those, a base of over 70 providers that send us internal referrals for management of chronic pain that's been there for at least 6 months or more. That can be a variance of any type of pain, whether that's a central nervous system pain disorder, fibromyalgia, chronic pain syndrome. A lot of it tends to be back pain, and things. For me, it's more of a long-term evaluation management of those pain patients. We do medication management, whether that's opioid therapy or looking for alternative medications, whether we're doing anti-inflammatories, tricyclic antidepressants, looking for interventional use of physical therapy, cognitive behavioral therapy, and then
most of which you have in-house. Is that correct?
Yeah. Pretty much we're trying to create everything so it's in-house to create a more collaborative, cohesive. So I can see the notes from physical therapy and see what they're specifically working on, and I can target that patient's next round of care. How do I best manage that with medications? I'm seeing an overburden of opioid use or things like that. Maybe we need to balance it a little bit more out with cognitive behavioral therapy. And so it's very nice because I can see all those notes, and those same providers, whether it's the family practice provider, again, sees that notes, and it makes it a very good collaborative care. So everybody knows what everybody else is doing.
I love that.
Yeah, when I first heard that, I was a little bit surprised, but then you start thinking about it, and that model just makes a lot of sense. There's not a lot of other primary care, family medicine-based groups that bring in an interventional pain physician.
Yeah.
But as you're describing it, that just makes a lot of sense for good patient care because you have in-house collaboration, and your group also has their own physical therapy office as well. So
it does. It really makes it so it's a one-stop shop, and like I say, that collaboration is huge. And that's one of the things where we've developed relationships with like Summit and with you guys. You know, we know each other a lot because we collaborate with these patients that we're doing conservative care, we're failing in care, they need to escalate to a surgical intervention. We work with you guys. You guys are great to give us back notes. I can read those notes. I know exactly what's going on. And again, when we're having conversations with patients that have failed and they're hesitant, they don't want to go to surgery, and we're a part of that pace of, hey, that's the next step. Otherwise, our quality of life is just opioids or this management that's not necessarily appropriate. And we can have that conversation and share and be like, no, these guys are great. We see their notes. We talk with them all the time. We know them personally, and this is what you can expect. And we smooth that collaboration even between interdisciplinary. But
yeah,
it's definitely a good benefit when it's all internal and in-house.
Yeah.
I think some of the cons that might be mentioned in that setting is that model rather is like I'm not going to use the term, but where everything is in-house and the quality of care can be compromised because it's all internal. There's no one checking. But I think what you're explaining to me is that the culture that you guys have built there and the types of providers that are there all have the same intention, which is to provide the best quality of care. And I think that just always has to be at the forefront. So for that model to be successful, and then also being willing to step outside of your network of people to go see other disciplines when it's appropriate. And so I don't know, I've been fascinated by that because I can see all the pros to intercollaborative care all in one setting, but also the challenges that can arise with just keeping the quality of care at an optimal level, if that makes sense.
It does very much make sense. And the nice thing is Premier really takes that into consideration of those cons, and we want to make sure that we are providing the best care, and we're not just a pill factory and come see us every month and we're running through. That's definitely not our mantra. And so we have these interdisciplinary committees that will review what we're doing. So we have a best prescribing practices. Hey, what's the best evidence on opioid management, co-prescribing with benzodiazepines, Z drugs, and how do we identify providers that may be having some issues with it, or we're seeing a trending data, so we can nip that in the bud. And that's a very big part of pain and spine as well. So not only do we get oversight by our collaborating family practice physicians, sports medicine physicians, things like that, but we're also soundboarding for those, so that if we can identify patients that are heading down that wrong pathway or running into those troubles, we can catch that early, and we can either bring them into pain and spine and help manage those types of more complex patients a little bit better, or we can help give suggestions of, hey, let's do more cognitive behavioral therapy, or let's look at alternatives like cannabis or tricyclics or guided imagery. I mean, all sorts of these evidence-based management data and give a better collaboration. So we do actually look at that and make sure the quality is there.
That's good.
And a lot of times our mantra is, hey, we're just one of many groups, and it's a tight knit group. We know all of the other pain guys in the community, and we're actually really good friends with them. We text each other all the time and collaborate with them. You've seen this patient, you saw struggles, they've came to us, and we do the same thing. So patients get passed around based off of looking for that, who's going to help me best, who's going to do the next thing. We're all doing kind of the same thing.
Yeah.
Some of us do certain specialties more than others, and it will kind of fill around. So even if it's not us, our goal is to get the patient better, improve quality of life. That quality of life may look different. Your quality, and my quality are all different. Our goal is to make your quality as best as it can be. And if we can't do it with us, we have no problem with passing you on to that next group. And unfortunately, we do it all the time, like sending them to you guys. Yeah. We've got to escalate your care to something else, or you're out of the wheelhouse with what we're comfortable with in managing your opioid burden. We need to send you to an interdisciplinary team like University of Utah's Intermountains that has a more pool that
that's fantastic. So my experience with not having ever worked in that world of pain and spine, my thought goes to what you're doing every day as the advanced practitioner in the office, because it's very procedural based. You guys do a lot of procedures, but that technically falls under the scope of the physician. So Dr. Brown, in your case, is probably fairly busy doing a lot of procedures. What's your day to day though? What keeps you busy?
So I do quite a few procedures myself. I'll do large joint injections. I'll do trigger point injections and Botox injections for different things. A lot of mine is the medication management, where we'll have them, all new patients will usually be evaluated with Dr. Brown. He'll create a plan of care. Usually I will follow along with that plan. We'll do a lot of follow-ups visits. So in any day, I could just see somebody that I've seen that's stable, needs medication refills, depending on what type. We could see them every 3 months, 6 months, or every month, depending on whether it's a controlled substance or not. Right. We can evaluate the success of intervention. So if we're doing a lumbar epidural injection, I'm usually seeing 2 weeks, 3 weeks afterwards, see if they had success, why didn't it work, why did it work, and what else is there. Because generally when we look at the etiologies of pain within the spine, there's not any one given thing. We may have spondylosis, arthritis, vertebrogenic type pain. We could see modic changes for chronic inflammation. We could see, disc herniations and facet, all these different things. And so as we see some success with one thing, usually we're peeling about and we're finding something else. And so a lot of times that secondary is, let's evaluate. So I do a lot of evaluation, diagnosis, physical exams with patients, and a lot of times come up with the next step. But usually it's under the guidance of a dictated note with what Dr. Brown has kind of initially seen. So we'll review MRIs. We'll do a lot of evaluation and plan of care and base. And then we do a lot of ordering to keep Dr. Brown doing what he does best, which is providing relief, injecting spines and things like that. So I do a lot of that kind of stuff. So it really varies from day to day, but a lot of it's medication management, but there's definitely a lot of it that is new diagnostic and evaluation and working with patients. A lot of it's evaluation, which is, or follow-up care, which can be very rewarding. You see patients that they couldn't walk, their legs are gone, they can't pick up their grandchildren, and I get to see them in the visits and like 90%, 100%'s gone. I was picking up my grandchild, I was playing, so stuff like that's extremely rewarding and can be a part of my day. And on the flip side, I got 0%. In fact, things got worse. I can't walk, my leg's completely numb. What's next? Sometimes it's you guys.
Yeah. Okay. So that's pretty engaging then. So you get a fair amount of back and forth. That's good. That wasn't what I had known about that. So I think that's interesting to kind of get a sense of what life's like.
Yeah. And on that end, how many patients then would you say you're seeing per day?
I'm a busy provider. We average anywhere between 25 to 30 patients a day.
Wow. How long are the appointment slots slated for?
15 minutes generally is what mine are. No, I'm always behind the later the day goes on because it's a 15 time slot, but that's time is, we don't care. We can balance it up. We'll work through lunch, whatever it is. We give the patient, the diligence they need to make sure we get a good plan of care.
I always tell patients, you're guaranteed the provider will be on time, start of the day and first one after lunch.
Yep.
And then from there, you never know.
Nope. And I always feel bad for those ones that are the very last ones of the day. And if I can catch up within 15 or 30 minutes, I feel like I'm doing pretty good. But sometimes it's a little bit later.
Yeah, I think we all experience that to some
You hear the horror stories of people's experience in the clinic setting, like waiting 2 hours in the lobby waiting to be pulled back. So definitely if we can keep it within a half an hour, 45 minutes, I feel pretty good about that pace, because it is tough and you want to give patients the time and effort needed to build that right plan of care, and it sometimes takes a little bit more than 15, 20, 30 minutes.
And what did it for me was having kids and trying to take my kids into the pediatrician. And I've gotten to know our pediatrician pretty well, and I know their office well, and they do a fantastic job. But if you have a sick little kid and you have other kids that also need you, and then you'd have to wait 30 minutes in a waiting room, that adds so much stress and anxiety and makes your life pretty tough. So now being on the flip side as the provider, it is
you want to be
you feel that burden, because I know what that's like to be.
I didn't realize though, on the other end, it's like as the provider, when you see a lobby full of patients, it gives you a little anxiety.
Yeah.
And so it's kind of just this back and forth emotional ride that you're trying to just balance and do the best you can. And it's a demanding job. Like you said, you got a busy clinic, you got patients that need to be seen, but there's only so much time in the day, so it's managing it all. So
it's for sure. And most of the patients understand that. We take enough time with them. And honestly, our time, we really don't have a whole lot of waiting time. We can get them back into rooms, and we're usually pretty well balanced with them. And it's like every clinic. You have those patients, they're coming in, they're stable, they're on a medication, we're refilling, you're screening to make sure there's no aberrant behavior, there's no adverse effects, everything's going great, pain's being managed great, let's refill it. That could be a 5-minute visit, but we've allotted it 15. So you can catch up in those aspects of it. Yeah. But and the other thing I always work to that aspect on the patient's perspective of it is, these are patients that haven't come in every month. In fact, I saw a patient today that mentioned, they work Salt Lake, way west of the airport and stuff like that. And so for them to come in and be seen, they have to take an entire day off of work. And that's a financial burden. That's a lot of strain. And then you're throwing that already onto somebody that has pain. So anxiety, depression have big aspects to those. And so we try to do our best to make sure that we can balance it out, but still be due diligent providers, make sure we're safe with our medications and things like that, and have to see them when we have to see them. But yeah we try to be as compassionate and aware of
the pain train. I think about in medicine, the buck, I mean, it stops at you. I mean, essentially when they show up at your door, it's like, okay, I'm here, you got to help me with my pain. And I think we've gotten a lot of opportunities to say, I think you should go talk to Jeff.
You got to go see Jeff.
Because I think he knows a lot more than I do about managing the pain.
True.
And so I can understand the magnitude of what you just spoke of all the different layers that add to that. Boy, I'm
interested though to get your take on that, of experiencing that interaction with a patient.
That could be a whole podcast in of itself.
I'm
sure about modalities of management of pain and stuff.
Yeah, but just, I mean, I guess the situation, that interaction with the patient that is a chronic pain patient, that's maybe high levels of opioids. Their MME is, I'm sure you've seen some high ones, but you are the guy. They've got to interact with you, and you're the one controlling that for them. And it's a big deal for them. How are those interactions with people?
They're pretty good. So I'm a very blunt, forward person, but I'm also a very compassionate person. So I understand patients have pain, and a lot of times it's just educating and giving them the knowledge of how do we manage that pain, and that they need to identify that they have a disease of pain and they are not their pain. And a lot of it starts initially mental, and how do we do it? So cognitive behavioral therapy, do you identify as you and you have a disease that happens to cause you a lot of pain, or are you your pain? And there's a big distinction in that on how it manages it. And then looking at where their willingness to work towards managing their pain. Most patients that you get in those situations are about the opioid, are about the MME, and I just need to get to my next pill. And we can go into that in depths and hours. And you have to break that cycle. And so a lot of times it's just being very blunt and open, but yet very compassionate and non-judgmental. I came from an emergency background. Everybody was a seeking behavior and everything. And it taught me a lot. And it really, I had to change my whole mindset when it came into pain management.
Because you come in with a bias.
You do. You really do.
People, and
those are the same people. They're my patients are the ones that are in the ERs all the time for these chronic pain things that a lot of times are very hard to document and find. Chronic pain syndrome, and we're starting to see a lot of Ehlers-Danlos syndrome, hyperreflexive issues coming on board. That what are we doing with that? Misdiagnosed fibromyalgia, and then you're talking about these back pains that the MRIs and the physical exam just aren't showing it. So there's a lot of cognitive issues that are associated to it that we have to address. And then you just have those patients that are arguably potentially a seeker. But again, my and Dr. Brown's take on this when I joined up with him, and one of the things that I had to have before I would join into this is that's still a disease. And I'm not going to turn somebody away because they have a higher MME burden, because they are a seeking behavior, because if I do, they're going to go to the guy that's not appropriate, that's going to run them up.
Right.
And I can help them from a good standpoint. And that may be that I have to prescribe them a higher MME, but we're going to work on that multimodal. We're going to work on cognitive behavior. We're going to try address pain at every synaptic cleft and with a different medication, whether that's low-dose naltrexone, whether that's amitriptyline, whether that's using NSAIDs. We can do it with medication management if we're going to do physical therapy. And each one of those, and I'll tell the patients, if we can get you 5% better here and 10% there, well, now we're getting you down 50%. And we can bring you down on your MME burden and stuff.
Multimodality.
And doing that with a very open, my goal is to very much help you. You're not in a good place, and this, we've got to fix that. And it actually worked really, really well for us. We have had patients that have come up with MMEs over 400, and within inside of 3 months, we're getting them down to 40 and 50.
That's amazing.
Pain may not be any better,
sure,
but their burden of illness is better, their mindset is better, their pain has not gotten any worse. And so a lot of time it's, that's a difficult balance that takes a lot of, I don't know if I'd say training or years or how to work with patients, but honestly, I think it's just your personality and your attitude with them a lot.
My question, I'm cutting you off, I already know.
You should do it.
Just tagging along with that now is me as a referring provider, someone who is also going to interact with that same patient. What advice or what would you say to referring and cooperative providers of what do you wish they knew about this scenario, or what do you wish that we could do better as collaborating providers?
I think just identifying which of those patients are going to be more difficult for you to manage and know where your comfort level is and to stop. Where we find most of these patients that have their opioid burdens well beyond 100 and 200 and 300 MMEs is that you've had a provider that could be compassionate and out of all good due diligence I'm trying to manage a patient who has started at a medication due to either just getting used to the medication and or my pain's gotten worse and I'm not trying to, or I had an acute injury and that made it worse, and so we're increasing, but then we never go back to the decrease, or we can't have that conversation because that's too difficult for me to be able to do that, or those manipulators on the patient side, they use emotion, they use anger, they use all these things to try and manipulate into more thing, and you can't learn how to deal with each one of those situations. So against their better judgment, they just continually to inch that opioid burden up. And so you almost have to set a standard and say, okay, I'm comfortable creating an opioid level and management up to a certain point. Like I say, in our best practices within Premier Family, our goal is, if you're a primary care provider and you're comfortable and you're keeping them around a 40-50 CDC guidelines, evidence shows most patients do fine at that, and that should be all they need to go to. If you're going above that, honestly, there seems to be no significant benefit, and that longevity of use creates hyperalgesic syndrome. Patients get on higher MMEs, their pain doesn't get any better. In fact, it gets worse.
Yeah.
And so that education, that
they're
conversation brings them down.
At that point. Yeah.
And so even for us on a pain clinic side, talk about these heavy MME burdens, ours is only 100. And so we really have rare patients over 100 MME in the pain clinic. If they're higher than that, they're probably beyond what we can do, and we should be sending them to some of our peers and looking for, intrathecal pumps, which we don't do, but we know some of our peers will send them out and stuff. And so even us, we have our identified limitations that we've set, and we utilize evidence-based practice and stuff and say, hey, this is where we're going to hold you. So for those that are out there, that if you're trying where do I stop? Well, follow the CDC guideline. Say you're a 50 or 40 or 60 MME. If you have a collaborative physician or a supervising physician, talk with them about it. Where are you comfortable about it? Where should we go? And set that number. And then that makes it easy because look, it's a policy that I can only take you to this far. And if you stop there, now that's my barrier to say, I can't, I either have to send you to pain and spine, or we have to hold you here and let's work on alternative treatments. And a lot of times that can be very therapeutic in itself.
Yeah, that's great advice.
Kind of brings it back to the collaborative state of mind, though. It's like we have a policy that we've designated within our practice with our surgical patients that anyone above an MME of 40, MME being morphine milliequivalents for those who may not know, you can calculate that. There's a whole bunch of calculators online that they can look that up, but 40 is what our kind of threshold is for doing surgery. And I think a lot of it's because of our comfort level of how much we're going to prescribe post-operatively. We've kind of designated that. And I think we always take into account every situation's different. And there's probably been patients there has been patients who have been on higher MMEs that we've taken into surgery. But I think it, like what you were discussing, is establishing what you're comfortable with, what your baseline is. And then obviously leaning on the CDC guidelines is super imperative to keep yourself up to speed with what's going on. Hopefully we're not going to see that they're going to say, higher MMEs is okay, but just being aware of what the information is out there, I think is great. Super helpful. I
mean, even beyond that, looking at what are your alternatives. So, we talk about your morphine meal equivalence burdens. To go into that a little bit more, that's, how do we define how much hydrocodone, how much oxycodone, how much fentanyl, how much methadone, and how do they interact with each other? Well, we have to create a common denominator, so we use morphine. Yeah. And so for every milligram of morphine, how does that equate to oxycodone? Well, oxycodone is 1.5 times more potent. So if I were saying I have a patient on hydrocodone 5 milligrams, I move to oxy 5, well, I actually increased their morphine burden to 7.5. So that gives, for those who aren't familiar with it, more of that barrier. Yeah. And so as we look at that morphine meal equivalent burden, and we're not comfortable with it, well, then be more comfortable with the alternative options. Let's look at buprenorphine in forms like Belbuca, that is dosing in microgram, as compared to buprenorphine dosing for opioid use disorder or heroin abuse and things like that. That's dosing in milligrams. So now you're talking like 1,000 times difference in these dosing things. So you got to be comfortable with understanding what is. If you're not comfortable with it, you should research it.
The buprenorphine requires a special license, correct?
It no longer does.
It doesn't.
It does not. So you don't have to have an X license anymore. I would still recommend you understand.
Get the education on it.
Because buprenorphine in pain management, like Belbuca, like I say, is microgram dosing, and buprenorphine in opioid use disorder is milligrams. So at a milligram dosing of 2 milligrams once or twice a day, you're talking 2,000 to 4,000 micrograms, where at the max on Belbuca, generally you're talking 900 twice a day, 1,800 micrograms. So you could even be double dosing on those doses. So you really got to look into it, understand it a little bit more, or even alternatives. So cannabis is a great one as well. So I'm a QMP. We have a lot of cannabis patients that come in and we utilize those. And it's understanding that as well. Cannabis has 9 different cannabinoids associated to what cannabis is. Each one of those cannabinoids has a different aspect to how we manage pain. And so we go over those, every time I introduce a patient to a cannabis, it's a half-hour visit. And we talk about the endocannabinoid system. We talk about each of the cannabinoids, CBG, CBN, CBC, CBD, THC9, and what each one of those do. And
you got all those?
Yeah, I think I did.
Locked them in.
Yeah.
Oh, and then we'll go over it and we're like, yeah, CBN, N stands for night. It's going to make you sleepy. G is good for pain. That's going to help with pain. C's for convulsions.
I feel like I'm in school again. That's what I had to do to remember everything.
D is more depression. So depression is going to be helpful for mood stabilization and anxiety. And so you've got your cannabinoids, THC, Delta 9. Hey, they tell us cannabis naive patients should be on a dose between 5 to 10. So I'll tell patients, count your fingers. You get extra fingers, you can have extra cannabis, but otherwise stick between cannabis, THC 5 and 10. And then, you could look into the plant strains, that changes it. You can look into your consumption methods, that changes it. So there's so many ways that you can manipulate cannabis that, it can be a very good option, but you have to educate yourself and know and be comfortable with that. And if you're not, hey, you should reach out to me. Reach out to someone.
Of course.
Let's have a mentorship or a conversation about it.
You sold me.
I'm sold. Yeah. One thing that always stood out to me that hit really hard was listening to one of the other pain management physicians in the Valley was presenting to our group one time, and he made the comment that a patient can overdose on their opioids by taking them exactly as prescribed, because there are so many influences that change the metabolism and the interaction between drugs, and you need somebody like Jeff that's knowledgeable and knows what to expect out of these encounters, because alluding to what you're saying, we have to be comfortable and understand what we're doing as providers and prescribers.
Well, and even further to that point, the evidence shows that if I do everything right, the patient does everything right, and 100% we're all on board and doing everything right, 1 in 4 patients, 25% are going to have either a physical or psychological dependence and addiction to those medications. And that's if we're doing it right.
Right.
So you take somebody who's not necessarily doing it right, finding that right patient under the right guidelines, the right education, that jumps. And so then you have that potential opioid use disorder disease burden we're throwing onto a patient that then now we've created a whole nother issue with them.
Do you find yourself in that setting leaning more towards the cannabinoids as for for treatment?
We do a lot. So we look at a couple things. So again, you look at the patient. No patient, there shouldn't be any cookie cutter in this kind of business. Mm-hmm. Every patient should be looked at differently. So if we have elderly patient, early signs of dementia, maybe some defined kidney function issues, they're already on Z drugs or potentially on a benzodiazepine, which may be appropriate. And we look and we try to get them off those drugs. We try to work with their family practice, say, hey, we're going to do this. We can't be on these types of drugs. Cannabis is an amazing option. Or if we have that patient that, I got to go up again. I don't have another option. Well, cannabis could be that next option to either keep them from not going up or even try and help them get back down or off of it. And so a lot of times it's good. But in of itself, it's still a Schedule I drug, so it's not regulated by the federal government, so insurance doesn't pay for it. So now there's a financial potential barrier burden to patients that you have to address with them. And you still have your potentials for risk. You can't smoke cannabis, but you can vape cannabis. And so there's all these things that, like I say, we take a good amount of time to go over and educate them on those.
For sure. How about, we'll kind of shift gears a little bit. Interested in kind of the lifestyle that you live, because that gets to be quite variable, as we've learned from all the different specialties that we've been chatting with. Is what's life like for somebody maybe that's interested in working in your setting, as far as, do you feel overburdened by your patient load? What's your work-life balance like? And then do you feel like the income and the reimbursement is adequate for what you're doing and appropriate?
Yeah. Work life's pretty good. I'm a little bit on the older side. Most of my kids are gone. I have a grandchild, hence the gray in my beard.
That's what does it. Okay.
And I've always been a workaholic. I've always had 2 or 3 jobs at a time, but Pain Spine's been great. We work 4 10s a day, or 4 10s a week. We're off Friday, Saturday, Sunday. No call, no shifts, no weekends. So it actually works really, really well. Wow. Where I get a little more busy is I actually still do like urgent care for our group. I'm the APC manager, so I oversee 40 nurse practitioner PAs for our group. So I have a lot of administration time that I do. My last paycheck was 103.5 hours. Most of them, but I do that to myself. So the work is there if I want to do it. Most of the time it's less, and the company encourages me not to go into overtime because they don't want burnout. And we look at burnout all the time. It's definitely something that's always high on our list as we're looking towards patients. But as far as the job goes, it's a great one. Like I say, no call, set schedule. The patient load is not that bad. It varies. day to day, but the patients are rewarding and great. You're always going to have in every discipline those patients that are just, gotta love them, but wish they'd go on.
Yeah.
But the rewards, like I say, you go see these patients that it's so debilitating. I can't go out into public. We've had a central patient with this central disease that any kind of light touch puts them into severe pain that lasts 5 to 10 minutes. And they've had it for decades and can't get it out. They can't go out in public, and you can't pat them on the arm. They're like, if you got to do my blood pressure, you just got to really grab hold of me, or it won't, or I'll be in pain and stuff like that. And we were able to do one of the things that are unique to our group that we do is lidocaine infusions, and we're able to do this that has worked for them amazingly, and now that quality of life is back. So it's very rewarding as well to be in pain and spine, because you get these patients that, when you work with them, they come down on those 400 MMEs to 100, or they're back to work, they're functioning, they're happy, they can play with their grandchildren. Oh, that's so rewarding, and to know that you had a big part of that, it's amazing. Spinal cord neuromodulation, oh my gosh, that's one of the most fun ones, where same thing, you failed on everything, you put a trial in and they cry at you, and it's like, don't take it out, it's the best I've ever been. And then you bring them back 4 weeks later after surgery, and they're like, it's gone, my pain's gone, I can finally do it.
It's amazing.
All the
gratifying.
Oh my
certainly.
gosh, amazing.
How about the compensation in that world? How does that compare to other areas? I know it sounds like you've had quite a vast experience in other specialties as well.
I have.
What would somebody expect?
So since I work in the administration side of it, and we're actually looking at how do we change compensation structures for APCs and things, and I've been working with our admin team about that. We're a salary based with bonus structure. And so depending on your RVU, patient seen per hour, and productivity, you can reach bonus structure that is multi-tiered. And so, if you're seeing 2.5 patients an hour, you should be into bonus structure. And if you're seeing more like 3 and 4, you can actually get into a pretty good chunk of bonus structure. But then in general, it's salaried, based off of MGMA, AGMA, which are these medication management groups. We look at their research data over the time, and we're pretty competitive and pretty much right in the middle of the road for where APCs should be in it. And we try to be pretty competitive with it. I don't know where my fellow APCs and things like that are. I can only speak to myself, but Premier Family has been very, very generous and good for me over the years that I've been with them. Raises are always usually, it's dependent on your productivity and how kind of an employee you are, what you bring into it, like everybody has an annual review, but they've always been good to me, and it's always been above cost of living and stuff like that. So
that's great.
And at least median or above.
Yeah, good. So you feel like somebody getting into the world of pain management would be at a pretty competitive rate, kind of across the board, compared to other specialties and things like that.
Yeah, definitely. Now, the one thing I would caution, and you guys could probably attest to it, is what we call the STP. And I'm not sure if you remember, but it's the same 10 problems. So the one thing that some patients or people can get into when you get into that specialty is you're seeing specialty. So you're going to see the same 10 complaints over and over again. And so sometimes that can feel like that's a burden on the job and a burnout. The trick is taking that into the context that you're changing people's lives and you're seeing these differences, and if you like to work with patients and get them better and improve that quality of life, that's where I think you'll see the reward of it. So financially, it's awesome. Time-wise, it's awesome. If you can get past that STP burden and like to work with patients.
Yeah, a little bit unavoidable though.
It really is.
Really, you're going to find that we've experienced the same thing. Being in a subspecialty, you're going to get a core set of things that we see a lot of.
And even in primary care, which I still do some primary care, but you see your diabetic checks, your Adderall refills, and blood pressure. You do see that same thing over and over again. But yeah,
that's a good perspective.
Love it.
How about story time? Should we finish it up with one last topic? This is one of my favorites. We'd love to hear if you've got a fun, interactive, memorable patient interaction story.
That one's really difficult for me because of my background from ER to family practice to occupational medicine, urgent care. Oh my gosh. And specifically within pain and spine. And I've kind of shared a couple of them where we've had some, but Tyler was mentioning to us, he had a really good one.
I'm so glad
I kind of want to hear this.
I've been waiting for this moment.
Fasciotomy kind of story, because those are always great stories.
Okay.
Dim the lights, everybody.
Yes.
Set the mood.
All right, here we go. So I'm going to take you back to my nursing days, okay, on the floor.
Nurse Tyler.
Nurse Tyler, maybe a year into nursing on the med-surg floor. I'm taking care of this patient, wonderful patient, mind you. He developed compartment syndrome, obviously, that's swelling of the leg, cutting off the vascular vessel supply, the blood supply to the leg, and requiring emergent surgery. And you perform a fasciotomy to basically open it up, alleviate the area of compression, allow everything to kind of breathe and for blood to flow accordingly. Well, I'm taking care of this patient, and I come on to shift, and the first thing I notice, he's got his wound bed just packed full of gauze, and it's already soaked in blood. So I'm getting rapport, and then I'm like, okay, what's going on here? And, well, he's got this little bleeding vessel here, and it looks like just a little spout of blood just kind of coming out. And I'm like, okay. And so I do what the nurse did before me, put new gauze on, keep packing it, changing it probably every 20 to 30 minutes. And then at the same time, I'm like getting my charge nurse on board. I'm like, okay, look at this. What do we think? What should we do? Okay, let's notify the surgeon. Well, sure enough, the surgeon's in the OR busy with a case and telling me, well, just, keep packing it and I'll be up there when I can. And I'm like, okay, everything's okay. And the patient's fine. I'm not seeing any decline in symptoms or anything like that. But a little worry about this heavily bleeding vessel coming out of this open flesh wound. And I'm like, oh my gosh, like, what are we doing here? So sure enough, I start to get worried enough. I think the family too was at the bedside were also worried. So they were like, okay, we need to do something. So I'm really pushing the surgeon. You really need to come up here. You need to take a look at this. It hasn't stopped bleeding my whole shift. Like, patient's obviously losing blood. Stable otherwise, mind you. But anyway, so he's like, okay, I'm going to finish this case. I'm going to send somebody up there that's going to bring a cauterizing tool. And at the time, I was like, I don't really know what that is. I haven't been encircled about the OR and know all the different equipment there. This lady shows up. She's sitting in the corner with this machine. I'm like, okay, like, cool. Something's going to happen. Sure enough, the surgeon shows up. He literally does not say anything to the patient. He walks in, looks at it. Oh, that looks bad. He hand gestures the gal to come in. She plugs in the machine, and he kind of looks at the cauterizing tool, and then he just proceeds to start zapping this patient's flesh in all these different areas that were probably not the area where he was bleeding. I mean, I just think he was just blindly going in. From my perspective, there may have been more tact to it than that, but my experience, and I am just in a state of shock and disarray. And the patient is gripping the handrails of his bed, trying to come off as burnt flesh is just illuminating the room. And all of the family is stark white. Everybody in the room we are all silent watching this. And he's, 3/4 away in the procedure, and he looks up and he's like, oh, I honestly think the surgeon thought the patient was asleep, like he was in surgery.
Back in the OR.
And he's like, maybe we should get you some IV drugs to help with the pain. Nurse, go get it. And I'm like, I was just frozen. So I run and get the IV morphine, get him with the IV fix, and he's feeling better. I was completely astonished by that. Like, I had never witnessed anything like that before in my life. And I thought, is this what the med-surg floor is? Is this what we do on a day-to-day basis? Come to find out that is not normal. That was kind of a one-off thing. I never saw that again, so I assume it was. Crazy story.
And it was a bipolar machine then, I'm assuming?
Yeah. Don't even remember. Can't even remember. Just remember seeing flesh. Smoke from the flesh, burning flesh coming up. It was insane. And the patient, I can't imagine how painful that was.
Oh, yeah.
I just can't, even to this day. And just the fact that we were just, everyone was in awe. And then he just walks out like it was normal. Like everything that just happened was
done.
normal.
Got it.
Yep, we got it.
Not bleeding.
Not bleeding anymore.
I mean, that's what's funny about those specialties. To him, that was normal.
Yeah.
He does it every day. 5, 6, 7 times. Cauterize all those little bleeding vessels. And
it's amazing though. Yeah, just the setting. We can come out of character. Just I don't even know how to explain that situation. I still don't to this day. But it was. I'll never forget it. Never.
That's awesome. That's awesome. I love it. Good story time. Okay, well, Jeff, it's been awesome having you here. Very enlightening. My favorite part of the discussion here. I get to turn to Tyler over here. Fill us in. What'd you learn today?
I love it. I love it. You know what? I actually like I think we spent a good amount of time just talking about the psychology of pain and kind of the layers that it has within it that need to be appreciated and respected. And truly, I think we all have our certain limitations with how comfortable we feel with managing pain, and it's so nice to know there are specialists in the community that have such a vast degree of knowledge and wisdom in it that we can lean on in the collaborative approach that needs to happen. And I just think we need to, as advanced practitioners, lean on that aspect, because we don't know all things. We know that we have the best intentions for our patients, but that doesn't mean that we always have the right recipe. So knowing when to turn to somebody else and say, hey, give me some advice. What should we do for this patient? I think it will give the patient hope. And it sounds like you guys are doing great things in a multimodal approach for pain management. It's not just centered around opioids. It's actually trying to figure out how to avoid as much opioid use as we can, finding other ways to improve one's quality of life. So I really appreciate your time and wisdom and knowledge that you shared with us today. And I think hopefully the listeners will feel the same way. So
I can't imagine they wouldn't. How would somebody reach out and connect with you, Jeff? If there was a patient, a fellow provider that wanted to have some follow-up questions or maybe refer to your clinic, how does somebody find you?
Yeah, so we could easily put our clinic contact information. We're on the Premier Family website. Out of our pain and spine location, they can find us through there. I'd have no problems if you guys wanted to, if they reach out to you guys and they need my contact information, I'd be happy to leave my contact information with you guys. So
great. Any social media presence at all for you?
Nothing that, well, I am on LinkedIn, but nothing, I really don't do a whole lot of social media. I blame that on the gray oldness. It's more I'm too busy and stuff like that. I am on LinkedIn, and that would be a good way that we could actually collaborate as well. That's about as far as I get, but yeah.
Perfect. Okay. Well, with our office, you can find us on Instagram at Summit Brain Spine and Orthopedics. Our YouTube channel is the Summit Medical Institute, and we love seeing people in person. So come hang out with us every Tuesday morning, 7 a.m. Our interdisciplinary case discussions, 7 a.m. at the Mountain Point Hospital in Lehigh, Utah. We appreciate special shout out Dallin Amelia on our production team helping us put this together. What else? Anything else?
I think that's it. Stay tuned.
Stay tuned. It's going to be good. We appreciate you again, Jeff. We'll wrap up our next installment here of the Many Minds podcast, using many minds and collaborative community healthcare to produce better outcomes for our patients. We'll see you next time.